Semaglutide Protocol for Effective Medical Weight Loss, a comprehensive guide. Semaglutide is a glucagon-like peptide 1 receptor agonist developed initially for type 2 diabetes that has demonstrated significant weight loss effects in clinical trials. This led to its FDA approval for chronic weight loss management in patients with obesity or overweight with at least one weight-related comorbidity. This course will provide an overview of semaglutide as a medical weight loss treatment option. Glucagon-like peptide 1 is released in response to food intake and regulates appetite and energy balance. Semaglutide mimics GLP-1 and is called a GLP-1 receptor agonist. Semaglutide binds to GLP-1 receptors in the brain to reduce appetite and food intake, in the stomach to slow gastric emptying, and in the pancreas to improve insulin secretion. This is an overview of semaglutide as a medical weight loss treatment option to equip you with the knowledge and tools needed to successfully incorporate semaglutide into your clinical practice for the management of obesity. Obesity is a global public health issue characterized by excessive body fat accumulation, which is typically measured using the body mass index. The World Health Organization defines obesity as a BMI of 30 or higher. Numerous chronic health conditions are associated with obesity, including type 2 diabetes, cardiovascular disease, hypertension, and certain cancers. Also, the psychosocial effects of obesity include depression, anxiety, and reduced quality of life. The complex etiology of obesity involves genetic, environmental, and behavioral factors that influence energy balance, appetite regulation, and metabolism. Dieting, exercise, pharmacotherapy, lifestyle interventions, and bariatric surgeries are current methods of medical weight loss. Various medical weight loss drugs can target appetite regulation, satiety, and/or metabolism to promote weight loss. Medical weight loss can significantly improve obesity-related comorbidities such as type 2 diabetes and cardiovascular disease. Even modest weight loss, 5 to 10% of initial body weight, yields significant health benefits. The selection of appropriate medical weight loss interventions by the physician depends on the individual patient's goals and comorbidities. A comprehensive, multidisciplinary approach that includes nutrition, exercise, cognitive behavior modification, and pharmacotherapy is essential for long-term success. Understanding glucagon and GLP-1. Glucagon and glucagon-like peptide 1, GLP-1, are two peptide hormones that regulate glucose homeostasis. Glucagon, a 29 amino acid hormone, is secreted by the alpha cell of the pancreatic islets in response to low blood glucose levels. It raises blood glucose levels by stimulating glycogenolysis and gluconeogenesis in the liver. Also, glucagon promotes lipolysis in adipose tissue, providing free fatty acids as an alternative energy source during periods of low glucose availability. Since insulin promotes glucose uptake and storage, glucagon is a counter-regulatory hormone. GLP-1, a 30 amino acid hormone, is secreted by the L cells of the gastrointestinal tract in response to food intake. GLP-1 helps in glucose homeostasis by enhancing glucose-dependent insulin secretion from the pancreatic beta cells, inhibiting glucagon secretion and delaying gastric emptying. These actions result in reduced postprandial glycemia and improved overall glycemic control. GLP-1 also has central effects on regulation of appetite and body weight, as it acts on the hypothalamus, to promote satiety and reduce food intake. Semaglutide is a glucagon-like peptide 1 receptor agonist, initially FDA approved for the treatment of type 2 diabetes. In clinical trials, it has demonstrated significant weight loss effects, leading to its FDA approval for the following indication and usage. Wegovy is a glucagon-like peptide 1 receptor agonist indicated as an adjunct to a reduced calorie diet and increased physical activity for chronic weight management in the following: adult patients with an initial body mass index of 30 kilograms per meter squared or greater, or 27 kilograms per meter squared or greater in the presence of at least one weight-related comorbid condition. Pediatric patients aged 12 years and older with an initial BMI at the 95th percentile or greater for age and sex. The mechanism of action of semaglutide mimics the effects of the native hormone GLP-1, which is released in response to food intake. By binding to the GLP-1 receptors in the brain, semaglutide reduces appetite and food intake. Additionally, semaglutide slows gastric emptying and improves insulin secretion, which improves glycemic control. The efficacy of semaglutide as a weight loss treatment option has been demonstrated in several clinical trials, including the SUSTAIN, semaglutide unabated sustainability in treatment of type 2 diabetes, and PIONEER, peptide innovation for early diabetes treatment, trials for type 2 diabetes, as well as the STEP, semaglutide treatment effect in people with obesity trials, which specifically focused on weight loss. These trials showed weight reduction and improved glycemic control. Semaglutide has the FDA approval for two indications: type 2 diabetes and chronic weight management in adults with obesity. Semaglutide, Ozempic, was first approved by the FDA in December 2017 as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. It is a once-weekly subcutaneous injection at doses of 0.5 milligrams or 1 milligram. In June 2021, the FDA approved semaglutide, or Wegovy, at a higher dose of 2.4 milligrams for chronic weight management in adults with obesity or overweight with at least one weight-related comorbidity such as type 2 diabetes, hypertension, or dyslipidemia. There are several other glucagon-like peptide 1 receptor agonists approved by the FDA for the treatment of type 2 diabetes. They include the following: lixisenatide. Pros include the following: improves glycemic control associated with weight loss. Cons include the following: relatively modest hemoglobin A1C reduction compared to other GLP-1 receptor agonists. Zenatide. The pros of zenatide include the following: improved glycemic control, promotes weight loss, and twice daily or once weekly dosing options. Cons include the following: higher incidence of gastrointestinal side effects compared to other GLP-1 receptor agonists. Liraglutide. The pros include the following: effective in improving glycemic control, associated with weight loss, and reduces risk of cardiovascular events. The cons include the following: potential increased risk of pancreatitis and thyroid C tumors. Dulaglutide. The pros include the following: effective in improving glycemic control, promotes weight loss. Cons include the following: possible risk of pancreatitis and thyroid C tumors. Semaglutide is a glucagon-like peptide 1 receptor agonist that mimics the effects of GLP-1, a hormone that regulates glucose homeostasis, appetite, and energy balance. Semaglutide has a 94% amino acid sequence homology with endogenous GLP-1. It has an extended half-life, 1 week, due to its structural modifications, allowing for once-weekly subcutaneous administration. The mechanism of action of semaglutide includes the following. 1. Enhanced glucose-dependent insulin secretion. Glucose-dependent stimulated insulin release from pancreatic beta cells, which improves glycemic control. 2. Suppress glucagon secretion. Inhibits glucagon release from pancreatic alpha cells, which reduces hepatic glucose production, which improves glycemic control. 3. Delay gastric emptying. Slows gastric emptying, which helps in reduce postprandial glucose excursion, which is the change in glucose concentration from before to after a meal, and promotes satiety. 4. Reduce appetite and caloric intake. It acts on the central nervous systems to regulate appetite. Clinical trial outcomes and safety profile. SUSTAIN, PIONEER, and STEPS are the three major clinical trials for the efficacy of semaglutide in type 2 diabetes and weight loss. The SUSTAIN, which stands for Semaglutide Unabated Sustainability in Treatment of Type 2 Diabetes, trials were a series of global randomized controlled clinical trials that investigated the efficacy and safety of semaglutide in patients with type 2 diabetes. The trial included 3,297 patients with type 2 diabetes and a high cardiovascular risk who were randomized to receive either semaglutide 0.5 mg or 1 mg subcutaneously once weekly or placebo. SUSTAIN 6 demonstrated a significant reduction in hemoglobin A1C levels and body weight compared to placebo, along with the reduction in cardiovascular risk. The results were the following. The primary outcome, composite of cardiovascular death, non-fatal myocardial infarction, or non-fatal strokes, occurred in 6.6 patients in the semaglutide group and 8.9 patients in the placebo group, indicating a 26% lower risk with semaglutide. Semaglutide led also to a significant reduction in hemoglobin A1C compared to the placebo. Patients receiving semaglutide experienced significant weight loss compared to those on placebo. The PIONEER trial stands for Peptide Innovation for Early Diabetes Treatment, were a series of global randomized controlled clinical trials that investigated the efficacy, safety, and tolerability of oral semaglutide. The trial included 3,183 patients with type 2 diabetes and established cardiovascular disease, chronic kidney disease, or both, who were randomized to receive either oral semaglutide, 14 mg, once daily, or placebo. PIONEER 6 showed that oral semaglutide significantly reduced hemoglobin A1C levels and body weight and was non-inferior to placebo in terms of safety. The results were as followed. Oral semaglutide reduced hemoglobin A1C levels compared to placebo. Oral semaglutide patients experienced significant weight loss compared to those on placebo. STEP trials stands for Semaglutide Treatment Effect in People with Obesity, were trials evaluated for the weight management of individuals with obesity. It was also a global randomized controlled clinical trials that investigated the efficacy and safety of subcutaneous semaglutide in individuals with obesity or overweight with diabetes. A total of 1,961 adult participants with a BMI of at least 30 or at least 27 with at least one weight-related comorbidity were randomized to receive either semaglutide 2.4 mg or placebo administered subcutaneously once weekly along with lifestyle intervention. Step 1 demonstrated that semaglutide led to a significant reduction in weight loss compared to placebo, with a mean weight loss of 14.9% in the semaglutide group. The results were as followed. The primary endpoint was the change in body weight from baseline to week 68. The patients in the semaglutide group experienced a mean weight loss of 14.9% compared to the 2.4% in the placebo group. Participants in the semaglutide group achieved a weight loss of at least 5%, 10%, or 15%, an improvement in secondary endpoints such as waist circumference, blood pressure, lipid level compared to the placebo group. Contraindications. According to the package insert, Wegovy is contraindicated in the patients with the following: a personal or family history of medullary thyroid carcinoma, patients with multiple endocrine neoplasm type 2, patients with a prior serious hypersensitivity reaction to semaglutide or to any of the excipients in Wegovy. Serious hypersensitivity reactions, including anaphylaxis and angioedema, have been reported with Wegovy. Limitations of use. According to the package insert, Wegovy should not be co-administered with other semaglutide-containing products or with any other GLP-1 receptor agonist. Safety and efficacy in combination with other products intended for weight loss, including prescription drugs, over-the-counter drugs, and herbal preparations, have not been established. Also, it has not been studied in patients with a history of pancreatitis. Warnings and precautions. The safety profile of semaglutide in the treatment of obesity has been investigated through several clinical trials. Here are the top warnings based on its clinical trials. Risk of thyroid C cell tumors. Patients' initial workup and maintenance physical exam should include thyroid exam, neck imaging. Serum calcitonin should also be measured. Acute pancreatitis. In clinical trials, acute pancreatitis was observed in patients treated with Wegovy. Patients should be monitored for signs and symptoms of acute pancreatitis. Semaglutide should be discontinued and not restarted if this complication should arise. Acute gallbladder disease. Rapid weight loss increases the risk of acute gallbladder disease. However, the incidence of gallbladder disease, even after factoring for the degree of weight loss, was greater in the semaglutide patients than in placebo. In clinical trials, in adult patients, cholelithiasis was reported in 1.6% of Wegovy patients versus 0.7% of placebo patients. Cholecystitis was reported in 0.6% of Wegovy patients and 0.2% of placebo patients. Also in clinical trials, in pediatric patients aged 12 years and older, cholelithiasis was reported in 3.8% of Wegovy patients and 0% of placebo patients. Cholecystitis was reported by 0.8% of Wegovy pediatric patients and 0% of placebo patients. Patients should be monitored for signs and symptoms of acute gallbladder disease. Hypoglycemia. Semaglutide lowers blood glucose and causes hypoglycemia. In clinical trials, hypoglycemia was reported in 6.2% of Wegovy patients versus 2.5% of placebo patients. There is an increased risk of hypoglycemia in patients who take semaglutide with other hypoglycemic medications, such as sulfonylurea or insulin. Patients should be warned of the risk of hypoglycemia, and blood glucose should be monitored in diabetic patients. Acute kidney injury. Patients have experienced acute kidney injury or worsening renal failure requiring dialysis. Renal function should be monitored when initiating or escalating the dose of semaglutide. Majority of the acute kidney injuries events occurred due to a patient experiencing adverse reactions like nausea, vomiting, diarrhea, or abdominal pain, which led to volume depletion. Hypersensitivity reaction. Anaphylaxis or angioedema has been reported in clinical trials. Patients with a history of hypersensitivity reaction to other GLP-1 receptor agonists should not be started on semaglutide. Diabetic retinopathy. Complications in patients with type 2 diabetes. Temporary worsening of diabetic retinopathy has been associated with rapid improvement in glucose control. In clinical trials, diabetic retinopathy was reported in 4% of Wegovy patients and 2.7% of placebo patients. Patients with a history of diabetic retinopathy should be closely monitored. Heart rate increase. Both adults and pediatric patients experience mean increases in resting heart rates of 1 to 4 beats per minute in semaglutide patients compared to placebo in clinical trials. Heart rate should be monitored at every checkup. Patients should be instructed to report palpitations or feeling a racing heartbeat while at rest. Semaglutide should be stopped if a patient experiences sustained increased heart rate. Suicidal behavior and ideation. Clinical studies shows a similar rate of psychiatric disorder in both semaglutide and placebo groups. However, patients with a history of suicidal thoughts were excluded from the clinical trial. Other weight loss medications have been linked to suicidal behavior and ideations. Therefore, it is advisable to monitor patients for mood and behavior disorders. Semaglutide should be avoided in patients with a history of depression or suicide. Semaglutide should be stopped in any patients with suicidal thoughts. Adverse events. According to clinical studies, gastrointestinal adverse events are the most common and tend to be mild or moderate, decreasing over time. Other common gastrointestinal adverse events include nausea, the most frequently reported adverse event with an incidence of 44% in the semaglutide group compared to 18% in the placebo group during the STEP 1 clinical trial. Diarrhea was number 2, which occurred in 28% of patients on the semaglutide STEP 1 trial compared to 12% in the placebo group. Vomiting occurred in 22% of patients on semaglutide compared to 7.5% in the placebo group. Constipation occurred in 18% of patients on semaglutide versus 6.8% in the placebo group. Other adverse events with an incidence greater or equal to 5% are as follows: abdominal pain, headache, fatigue, dyspepsia, dizziness, abdominal distension, eructation, hypoglycemia in patients with type 2 diabetes, flatulence, gastroenteritis, gastroesophageal reflux disease, and nasopharyngitis. In conclusion, the safety profile of semaglutide in obesity treatment is generally favorable, but post-marketing surveillance will give physicians and patients a greater clarity. Comparison with other weight loss medications. Several research studies have compared the efficacy of semaglutide to other GLP-1 receptor agonist medications. Semaglutide versus liraglutide. A 20-week randomized double-blind controlled trial compared the weight loss effects of semaglutide to liraglutide in 957 participants with obesity. Semaglutide treatment resulted in a mean weight loss of 13%, while liraglutide treatment resulted in a mean weight loss of 7.8%. Semaglutide was found to be more effective than liraglutide in achieving weight loss. Semaglutide versus dulaglutide. An open-label parallel group phase 3b trial was done at 194 hospitals compared the effects of semaglutide to dulaglutide in 1,201 participants with type 2 diabetes. Semaglutide treatment resulted in a greater weight loss than dulaglutide at both dosage levels. The mean weight loss was 4.6 kilograms with semaglutide 1 milligram dose versus 2.3 kilograms with dulaglutide at 1.5 milligrams, and mean weight loss of 3 kilograms with semaglutide at 0.5 milligram versus 1.5 kilograms of weight loss with dulaglutide in the 0.75 milligram dose. These clinical studies suggest that semaglutide is more effective than other GLP-1 receptor agonists in promoting weight loss. However, it is important for the physicians to weigh the side effect profile of these medications and other individual patient factors when selecting a weight loss medication. Patient selection and assessment. Criteria for patient eligibility, medical history, and contraindications. According to the package insert, Wegovy semaglutide injection 2.4 milligrams is indicated as an adjunct to reduced caloric diet and increase physical activity for chronic weight loss management in the following: adults with an initial body mass index of 30 kilograms per meter square or 27 kilograms per meter squared in the presence of at least one weight-related comorbid condition, such as hypertension, type 2 diabetes mellitus, or dyslipidemia. Also, in pediatric patients aged 12 years and older with an initial BMI at the 95 percentile or greater standardized for age and sex. It is not indicated in the following patients: patients with a personal or family history of medullary thyroid carcinoma. Also in patients with multiple endocrine neoplasm type 2. Also, it should not be started on patients with a prior serious hypersensitivity reaction to semaglutide or to any of the excipients in semaglutide. Warnings and precautions to the following. Risks include thyroid C-cell tumors, acute pancreatitis, acute gallbladder disease, hypoglycemia, acute kidney injury, hypersensitivity reactions, diabetic retinopathy complications in patients with type 2 diabetes, heart rate increase, and suicide behavior and ideation. In addition, patients should be warned about the following. In history of type 1 diabetics or ketoacidosis, semaglutide is not indicated for these conditions. History of gastrointestinal disorder, such as gastroparesis or inflammatory bowel disease, should be warned as semaglutide may slow gastric emptying and worsen the diseases. Potential drug interactions, especially those that have narrow therapeutic index or require close monitoring, such as oral anticoagulants, antiplatelet agents, antihypertensive medications, and other anti-diabetic medications. Pregnancies and breastfeeding. Semaglutide is classified as a pregnancy category C. It is unknown whether semaglutide is excreted in human milk. Potential drug interactions and considerations. Based on research studies, the following drug interactions and considerations should be taken into account when using semaglutide. Oral medications. Semaglutide slows gastric emptying, which can affect the absorption of other oral medications. It is essential to monitor the efficacy of other oral medication and adjust dosage as needed. Insulin and sulfonylureas. Semaglutide increases the risk of hypoglycemia when used with other medications used to control hyperglycemia. Semaglutide used in patients using insulin has not been evaluated. Warfarin and other anticoagulants. Semaglutide increases the risk of bleeding when used with anticoagulants. Alcohol. Semaglutide mixed with alcohol may potentially affect the liver or cause hypoglycemia. Use in pregnancy. Semaglutide has not been tested on pregnant women. Discontinue semaglutide when the patient is pregnant. Also, it should be stopped at least 2 months before planning for pregnancy. Baseline measurement and laboratory tests. Before initiating semaglutide treatment, the following baseline measurements and laboratory tests should be considered. Body weight and body mass index, blood pressure, and heart rate should be measured in all patients before starting them on semaglutide. Laboratory tests such as glucose, lipid profile, renal function, thyroid function, and liver function should be performed in all patients prior to starting them on semaglutide. Semaglutide protocol implementation. Starting dose and titration schedule. Wegovy is a pre-filled single-dose pen that delivers a dose of 0.25 milligrams, 0.5 milligrams, 1 milligram, and 1.7 milligram, or 2.4 milligram. Ozempic is a pre-filled multi-dose single-patient use pen that delivers the following: 2 milligrams in 3 mLs, that delivers 0.25 milligrams or 0.5 milligrams per injection, 4 milligram per 3 ml, that delivers 1 milligram per injection or 8 milligram per 3 ml, that delivers 2 milligrams per injection. The semaglutide starting dose titration schedules are important to minimize side effects and ensure optimal therapeutic efficacy. The recommended semaglutide dosing schedule, as per the prescribing information and clinical trials, is as follows. Administer Wegovy once weekly on the same day each week at any time of day with or without meals. Inject subcutaneously in the abdomen, thigh, or upper arm, alternating injection site. In 4-week intervals, increase the dose until a dose of 2.4 milligrams is reached. For example, weeks 1 through 4 initiate at 0.25 milligrams once per week for 4 weeks. Weeks 5 to 8 initiate 0.5 milligrams once weekly for 4 weeks. Weeks 9 through 12 initiate at 1 milligram once weekly for 4 weeks. Weeks 13 to 16 initiate 1.7 milligrams once weekly for 4 weeks. Week 17 to 20 initiate at 2.4 milligrams once weekly for 4 weeks. The maintenance dose of Wegovy is 2.4 milligrams once weekly. Ozempic does not have a 1.7 milligram or a 2.4 milligram dosing pre-filled pen. The dose escalation should be dependent on the patient's side effect profile and gastrointestinal tolerability. If the patient does not tolerate a dose, then consider stopping or delaying the dose escalation for 4 weeks. If a dose is missed, then it should be administered as soon as possible within 2 days of the missed dose. If more than 2 days have passed, then the patient should skip the missed dose and administer the next dose on the regularly scheduled day. Patients should not administer 2 doses within the same week. If a patient discontinues semaglutide for more than 2 weeks, then it is recommended to reinitiate treatment at the 0.25 milligrams once weekly dose and follow the original titration schedule. If the patient cannot tolerate 2.4 milligram dose, then decrease the dose to 1.7 milligrams for 4 weeks. After 4 weeks, increase the dose to the maintenance dose of 2.4 milligrams. If the patient cannot tolerate the 2.4 milligram dose, then discontinue semaglutide. The American Association of Clinical Endocrinologists and the American College of Endocrinology guidelines recommend that patients receiving treatments for obesity be evaluated every 4 to 12 weeks. During the first few months of the treatment, when dosing titration occurs, it is essential to maintain close monitoring for side effects. Once the patient has reached the maintenance dose, follow-up appointments can be scheduled according to the needs of the patient. More frequent follow-ups may be required if the patient is experiencing side effects. Nutrition and lifestyle counseling. The role of dietary intervention in semaglutide treatment. The role of dietary modification in semaglutide treatment is essential. STEP, PIONEER, and sustained clinical trials shows that combining dietary changes with semaglutide helped achieve better weight loss and glycemic control. Consuming smaller, low-calorie, more frequent meals and avoiding high-fat foods can also help minimize gastrointestinal side effects. Some weight loss clinics have recommended the post-gastric bypass diet protocol to minimize calories and gastrointestinal side effects. The efficacy of this practice has not been proven in clinical trials. A common diet modification method is to consume 500 to 750 fewer calories per day than the individual's estimated energy requirement. However, low-calorie diets should be tailored to the individual patient, taking into account lifestyle and medical conditions. Ideally, the patient should work together with a dietitian to develop a personalized diet plan that is sustainable and nutritionally balanced. Exercise recommendation and patient motivation. Exercise recommendations were combined with semaglutide in the major clinical trials. Specific exercise routine varies between studies, but general goal was to achieve at least 150 minutes of moderate intensity aerobic exercise per week. Ideally, the patient should work together with a personal trainer to develop a personalized exercise plan that is sustainable and physically safe. In clinical trials involving semaglutide, patient motivation and support were integral components of the treatment plan. In the STEP trial, patients received counseling sessions to support and motivate patients. These sessions focused on learning about behavior modification, self-motivation, and diet and exercise recommendations. Some effective motivational strategies include the following: establishing trust with the patient, setting realistic and achievable goals, providing positive reinforcement and celebrating successes, identifying and addressing barrier to adherence, offering resources and tools to help patients track their progress, and providing ongoing follow-up support. Maintaining motivation is a key part of successful weight loss intervention. The physician needs to adopt a patient-centered model using evidence-based medicine to motivate and transform. Behavior modification strategies and support resources. In clinical trials, behavior modification strategies were combined with semaglutide. Some effective behavior modification strategies include the following: goal setting. Encouraging patients to set specific, measurable, achievable, relevant, and time-bound, also known as SMART, goals related to weight loss, dietary changes, and physical activity. Self-monitoring. Encouraging patients to track their daily food intake, physical activity, and weight to increase self-awareness, identify patterns, and facilitate behavior change. Stimulus control. Helping patients identify and modify environmental cues that may trigger unhealthy behaviors, such as avoiding keeping unhealthy foods at home or finding alternative ways to manage stress. Problem solving. Teaching patients to identify barriers to behavior change and develop strategies to overcome these obstacles. Cognitive restructuring. Helping patients identify and challenge negative thoughts or beliefs that may hinder their weight loss efforts and replace them with more positive, adaptive thoughts. And finally, social support. Encouraging patients to seek support from friends, family, or support groups to enhance motivation, accountability, and adherence to lifestyle changes. Behavior modification plays a critical role in maintaining weight loss. Physicians must incorporate evidence-based strategies to support patients to make long-lasting lifestyle changes. Long-term management and follow-up. Addressing barriers to adherence and long-term success. Adherence to semaglutide treatment for weight loss can be influenced by many factors. Other potential barriers include the following. Side effects. Gradual titration, education, and close follow-ups may help patients manage any side effects and improve adherence. Injection-related. Some patients will experience fear and discomfort related to the self-administered subcutaneous injection of semaglutide. Proper education and demonstration may help address the anxiety in the patient. Price. The cost of semaglutide treatment can vary depending on insurance coverage. Physicians should discuss long-term costs of semaglutide and provide financial resources or assistance program as needed. Ongoing support and education customized to each individual patient can address barriers to long-term success with semaglutide. Assessing treatment effectiveness. Obviously, weight loss is the primary goal in assessing treatment effectiveness of semaglutide for weight loss. However, other end measures should be taken into account based on medical literature. Going back to weight loss, in the STEP trial, patients treated with semaglutide achieved a mean weight loss of 14 to 17% of their baseline body weight. Glycemic control. The SUSTAIN trial reported that semaglutide reduced hemoglobin A1C levels in type 2 diabetics more effectively than other competitors. Cardiovascular outcomes. The SUSTAIN 6 trial showed that semaglutide reduced the risk of major adverse cardiovascular events in patients with type 2 diabetes. Other health parameters. Semaglutide has been associated with improvement in blood pressure, lipid profile, and markers of renal functions as well. Regular follow-ups and dose adjustment can help ensure optimal outcome for your patients. Strategies for maintaining weight loss after semaglutide discontinuation. When semaglutide is discontinued, the appetite of the individual may increase back to its baseline. A 2022 study found that patients on average regained 2/3 of the weight when semaglutide was discontinued. Maintaining weight loss after discontinuing semaglutide can be challenging. Long-term lifestyle modification, behavior strategies, and ongoing support is essential to prevent relapse. In some cases, alternative weight loss medications may be considered for patients who require additional pharmaceutical support for weight loss management. Compounding pharmacies and semaglutide. What is a compounding pharmacy? Compounding pharmacies create customized medications by altering, combining, or mixing active pharmaceutical ingredients to cater to specific patient needs, such as creating formulations that are free of allergens, altering dosage forms, or combining multiple medication into a single dose. What is off-label use of medications? Off-label use refers to the prescription of an FDA-approved medication for a purpose, dosage, or population that is not explicitly approved by the FDA. Physicians prescribe medications off-label based on their professional judgment as long as they believe it is in the best interest of the patient. FDA's role in compounding and off-label use. Compounding pharmacies are subject to FDA regulations to ensure they meet specific standards for safety and efficacy. However, the FDA does not regulate the practice of medicine and do not oversee the off-label use of medications. The decision to prescribe a medicine off-label is at the physician's discretion based on medical judgment, scientific evidence, and the patient's best interest. Balancing benefits and risks. There are potential risks associated with these compounding of medication, such as varying quality, potency, and purity of compounded medications, or lack of substantial evidence supporting off-label use. Physicians should carefully weigh the benefits and the risk of using compounded medication while adhering to regulatory guidelines and professional standards. The safety and efficacy of compounded semaglutide does not go through rigorous oversight like the FDA-approved semaglutide formulations such as Ozempic and Wegovy. Compounded semaglutide vary in quality, potency, and purity, which can lead to suboptimal treatment outcomes or adverse events. Finally, many of the compound pharmacies are not transparent about how they are sourcing the semaglutide. Novo Nordisk, the manufacturer of Ozempic and Wegovy, said that it does not provide semaglutide to these compounded pharmacies. Industry insiders speculate that compound pharmacists could be giving patients semaglutide sodium, a cheaper and modified version that is intended for research use only. Compounding pharmacies could also be purchasing high doses of semaglutide from wholesalers and then separating it into smaller dosages or mixing it with other drug ingredients. Considering the potential risks associated with compounded semaglutide, physicians should prioritize prescribing FDA-approved semaglutide. Adhering to FDA guidelines and best practices, physicians can optimize care while minimizing potential risks to patients and legal implications related to compounded semaglutide. Semaglutide in clinical practice. Currently, there are two specific types of semaglutide medical weight loss treatment practices. First type uses the FDA-approved Wegovy for medical weight loss for obese patients. These practices actually use semaglutide as per the on-label FDA indication. Depending on the insurance, the cost of the drug is discounted or covered as well as the medical visit. Prior authorization is needed if the patient meets the FDA approval indication. If you have problems with prior authorizations, a local specialty pharmacy may be able to help you. The coverage amount varies from states and insurance companies from 50% to 80%. Currently, Novo Nordisk is offering Wegovy savings card with a discount of $500 if the patient does not use insurance, which makes the final cost around $800. Laboratory testing and imaging studies are ordered as needed. The appropriate CPT code is used and billed accordingly. Currently, the sample dosage costs are as followed from GoodRx. Ozempic is $884.82 per single patient use pen. Wegovy is $1,333.91 per carton, which contains 4 pre-filled single-dose pens. The best practices for prescribing FDA-approved semaglutide would be to follow the clinical trial protocol. You can read the Step 1 clinical trial protocol in detail and study the flowchart from their page 10 here. Second type uses a non-FDA-approved semaglutide that has been compounded with another drug or supplement by a compound pharmacy. FAQ about compounded semaglutide. Where do I buy compound semaglutide? Various compound pharmacies offer and ship to various states. These compound pharmacies include the following. Thank you for listening and watching our semaglutide medical weight loss training for clinicians. If you would like to learn about the semaglutide treatment protocol implementation, then go to medicalweightlosstraining.com and sign up for the online medical weight loss training course. This is Dr. J. Park. Thank you very much.